All right, yes, absolutely. So we're going to continue on with our antihypertensives. This will be section 1 of this. First thing we're talking about is diuretics. So hopefully everyone used the bathroom before they came back from break, right? Hopefully. Okay. So basically what we're looking at as far as diuretics go, these are going to be drugs that increase urine flow and or increase sodium and chloride excretion. At a baseline, that's what a diuretic's doing. Obviously if we have sustained imbalance between our sodium and chloride, either intake or loss, that can be fatal. Obviously having too much volume overload can lead to things like pulmonary edema. Having too little can lead to volume depletion and cardiovascular collapse. Does anyone remember that story of hold your wee for a wee? Yeah, what happened?
She died.
Well, she died. What would she do to die?
Drink too much water and pee.
Right, exactly. So just way too much water, and that basically led to a delusional hyponatremia, which ended up leading to seizures and all kinds of bad stuff. She ended up dying. So really anything can be poisonous in too big a dose. But so obviously the big thing here is your kidneys are really regulating how much volume you're keeping on board, and it's also regulating salt and chloride excretion. Right, so electrolyte imbalances and things like that are helped to be controlled by the kidneys. So we see that kidneys receive a large amount of the cardiac output, about 22% of it or so, and uses a pretty significant amount of oxygen given the actual size of the kidneys in relation to the body itself. We're going to see that this is the renal compensatory mechanisms are really, really important in regards to a lot of the other medications we're going to be looking at. So when the kidneys start to sense that there's some sort of volume depletion, they're not getting enough blood flow, they're going to start this process called diuretic braking. So essentially what they're going to do is they're going to start activating the sympathetic nervous system. They're going to start activating the renin-angiotensin-aldosterone system. Which you already know some of their antihypertensives work directly on that system. They're going to start to do things by decreasing blood pressure, by decreasing this pressure natriuresis process there. Decreased atrial natriuretic peptide, increases in antidiuretic hormone. And then you end up even seeing some renal cell hypertrophy, which may be more of kind of a prolonged thing. But basically, the kidneys are just trying to do everything to help increase that blood flow, because again, they're kind of sensing things that say, hey, there's not enough volume here. There's probably not enough volume elsewhere as well, right? So this is also where you see like a lot of issues where we'll look at things like the afferent, efferent arterioles and looking at different drugs that affect those, and as far as vasoconstriction and dilation goes. But essentially, all of it goes back to the kidneys are trying to regulate good blood flow in order to help regulate their blood volume. So you guys, I'm sure I've seen all this before. It's important to look at the different components of the nephron itself, because different diuretics are going to work at different points, and so it's important to remember where those are working at, because we'll look at things like resistance to certain type of diuretics and how that can be overcome. So you guys at least covered some nephrology at all? At least in anatomy, at least know what the nephron looks like and whatnot, all the different components. So obviously things are going to start off by being filtered through the glomerulus and Bowman's capsule and eventually lead to the proximal convoluted tubule. We'll end up seeing some drugs work there. They'll also have the loop of Henle, which is really important for sodium concentration and also reabsorption of water. And then you'll have your distal convoluted tubule and collecting duct. So you'll see that different diuretics are working at different sites in order to help make sure that whatever's being filtered through the glomerulus, we try to reabsorb what we need to while excreting whatever waste we need. So we're going to be filtering out things like glucose, different electrolytes. Bicarbonate's going to be on there as well, which is important when we talk about carbonic anhydrase inhibitors, amino acids as well. So even though we're filtering tons and tons and tons of liters of fluid a day, we're maybe only excreting out, say, 1 to 2 liters. So again, that reabsorption process is really important. And basically what we're going to see is our diuretics are inhibiting that reabsorption process in order to lead to diuresis. So looking here at the proximal tubule, you end up seeing that it's responsible for things like reabsorption of glucose, amino acids, organic solutes. You see a significant amount of reabsorption of water happening here, so 60 to 70% is happening here. You're going to see that, as far as diuretics go, you're not going to have a ton of really high potency agents working at the proximal tubule. We're going to see more of those working more, say, in the loop of Henle and distal convoluted tubule in general. Loop of Henle is really important for this concentrating of the urine and sodium reabsorption. So see that in the descending loop is where you're having a lot of water being reabsorbed from, but in the ascending loop, this is where we can affect sodium reabsorption, and this will be important for some of our diuretics, like our loop diuretics, obviously because they work in the loop of Henle, but they'll be working specifically on this ascending loop, right? We'll then see that the distal convoluted tube will be another site. You'll see that some water movement is affected by aldosterone, and we'll have some drugs working specifically by antagonizing the effects of aldosterone. But this is where our thiazide diuretics are going to be working. And then you'll have the collecting duct. You'll have aldosterone having an effect here as well, along with ADH, or antidiuretic hormone. And then this is also where potassium-sparing diuretics are going to be working. Does anyone know why alcohol makes you urinate? Yeah, so it's actually inhibiting ADH. So by inhibiting antidiuretic hormone, antidiuretics, so anti-urination, that's where we end up seeing a lot of that increased urine flow comes from. So don't break the seal. Just kidding, you guys are students, you shouldn't be drinking. Anywho, so the first group we'll talk about are going to be our loop diuretics. So essentially what these are doing are working in the ascending loop of Henle. They're going to be inhibiting this transport of this sodium, chloride, and potassium carrier that's on the luminal membrane of the thick ascending loop of Henle. And so there's 4 agents that go into this category. We're going to have furosemide, which is Lasix. I'm sure you guys have heard of Lasix before, right? Does anyone know where the name Lasix comes from? It lasts about 6 hours. Lasix. That's where it comes from. So it lasts about 6 hours. That's what they say. Do you ever need to know how long it works for? That's true. I didn't make that up. Then you also have bumetanide or Bumex. You have torsemide or Demodex, and then you have this other one that doesn't get used quite so often, but ethacrynic acid or Edecrine. The main thing that you're going to see ethacrynic acid being used for is usually going to be an allergy to the other agents. These other agents are working. They're basically are sulfa drugs, and so if you had a sulfa allergy, you would want to avoid those. In which case, you could use ethacrynic acid instead. The only things I'm noting here, these micromolar concentrations are the relative potencies of the agents. Notice that furosemide is kind of the least potent, whereas you have bumetanide and torsemide being much more potent. So essentially what you're seeing though is that your doses are going to be smaller for those 2 agents versus like Lasix. So instead of giving like say 40 milligrams of Lasix, you may only give say 1 milligram of torsemide or Bumex or something like that. So just for your information. Again, looking at this slide here, you can see the lumen where you see the urine flow is occurring, and then you have the interstitium or the blood. Essentially what we're inhibiting is that channel there, that sodium potassium chloride channel. And again, the important thing to note when you're looking at these diuretics is that wherever the solutes go, water follows, right? Because water likes to go from areas of, it likes to follow the solutes, so make sure everything is kept at kind of a uniform concentration. So if the solutes are going to be inhibited from crossing these cells, and they're kept out in the lumen where all the rest of the urine is, where's the water going to flow? It's going to stay right there, right? It's not going to be reabsorbed into the blood because all that solute is still sitting there in the actual duct itself. So that's why that's working. That's why you're inhibiting. That's why you're going to see increased levels of sodium, chloride, and potassium. There will be increased outflow if you're to measure the kidney electrolyte or the urine electrolytes. But you're also going to see that magnesium and calcium are being affected as well. Right. So the thing you really worry about when giving loop diuretics is you worry about electrolyte imbalances because you're going to be losing a lot of electrolytes here. So again, you can inhibit sodium chloride reabsorption by about 20 to 25% by giving one of these diuretics, these loop diuretics. So you can increase urine output pretty significantly for the most part. Like we mentioned, you'll have increased potassium excretion as well, along with calcium and magnesium excretion. So if your patient was, say, at risk for developing arrhythmias, and you start to monkey around with their calcium or their potassium, that may lead them to bigger risk for having an arrhythmia, right? So it's really important to make sure you're monitoring patients' electrolytes while they're on these medications, or just give them a banana or something, right? It's not good. You should probably monitor their electrolytes. Anywho, other actions you may be able to see, and a lot of this is due to that diuretic braking the kidneys are inducing. So some of the things you're going to see is that by having hypokalemia, potassium is really useful for helping the beta cells in the pancreas release insulin. So by decreasing that, you may have impaired insulin release, which can lead to hyperglycemia. You also can see reflex activation of the sympathetic nervous system, which means you're releasing catecholamines like norepinephrine and epinephrine, and that's going to be activating things like the alpha-2 receptors and the beta-2 receptors, both of which can either impair insulin release or increase glycogenolysis, which increases blood glucose concentration. So Again, all those things kind of mixing up together to mean your patient's blood glucose should be elevated to some degree. Not as much as you would see with something like a glucocorticoid, but certainly to some degree you'll see an increase there. Other things you'll be seeing as well is that you'll have this systemic vasodilator action that can occur as a reflex to this, so it can stimulate prostaglandin synthesis. Again, so looking at the nephron, you're looking at the arterioles that are coming into and out of the nephron itself. So you have the afferent arterioles coming in, and you have the efferent arterioles going out, right? So the afferent arterioles, if you close down those by causing a vasoconstrictor to clasp down on that, what's that going to do to urine blood flow, or to kidney blood flow? Should decrease it, right? So if I have a prostaglandin that has vasodilatory actions, it's going to help to relax that. You're going to have increased kidney blood flow, right? So again, same reason why NSAIDs cause a decrease in kidney blood flow, which can worsen your hypertension, is because it's decreasing the amount of prostaglandins that are being formed there, affecting that afferent arteriole. So same thing's happening here, but when you have that activation of prostaglandin formation, it's going to cause a vasodilatory action to increase the amount of blood flow going to the kidneys. Other things you're going to see in relation to just decrease in blood volume is going to include increases in the renin-angiotensin system, which we'll talk about extensively once we get to our ACE inhibitors. You'll also see increased activity of aldosterone and antidiuretic hormone. Other things we can potentially see as well as effects on uric acid, so you'll end up seeing decreased excretion and thus increased plasma blood levels of uric acid. So if a patient has gout, may lead to worsened exacerbation of that. Some other things you can see as well would include things like a mild metabolic alkalosis. So there's this idea called contraction alkalosis, where essentially by decreasing the actual total blood volume you have in the circulatory system, you can actually end up increasing your bicarbonate concentration, which can lead to that alkalosis. And then it also works by enhancing hydrogen ion secretion within the urine itself, which can be another major reason for that alkalosis. This will also lead, due to that sympathetic nervous system activation, can actually lead to increased triglycerides as well, so it may actually worsen some of your hyperlipidemia. So other things to note here as well is that loop diuretics are effective for patients even have very significant renal dysfunction. So even if they have creatinine clearance rates below 30, these ones are still going to be effective. And that's going to be an important differentiator when we get to our thiazide diuretics. So remember that point for a little bit later. Okay, so where might we use our loop diuretics? These are not great antihypertensives. So they're kind of okay, but there's a lot of compensatory mechanisms that occur that we talked about. They kind of lead them to not be great antihypertensives. Other things you will see them being used for, though, is fluid overload. So certainly if you have pulmonary edema happening, if you were to have cirrhosis of the liver, so you have ascites and you have lots of fluid overload, those can all be good uses for that. Things like hypercalcemia, because we saw that by blocking that transporter within the ascending loop of Henle, you end up having increased calcium excretion, so that could be useful for that. Heart failure, you might have volume overload, that would be useful to get rid of that. And then also, if you're ever having renal failure or insufficiency and having fluid buildup because of that, loop diuretics might be useful. So even though you might have kidney failure, these will still remain effective even though if you have creatinine clearances below 30 mLs a minute. So we mentioned some of the compensatory mechanisms, which is also going to be some of the adverse effects we're going to be seeing. So certainly that fluid depletion can lead to a lot of those reflex mechanisms. You see hypokalemia, so again, that may aggravate some arrhythmias. The patient is particularly at risk. Hyperglycemia, so again, higher blood glucose may make some of your anti-diabetic medications less effective. Gout, and then some other things that may be not quite so informed by the reflex mechanisms is going to be its ototoxicity. So certainly you can see damage to the hair cells in the cochlea, so kind of similar to what we saw with some of our antibiotics like vancomycin, aminoglycosides. All right, those are big ones that cause ototoxicity. And it wouldn't be totally uncommon to see someone who would be in the ICU on vancomycin, Lasix, and also on gentamicin. So be one of those things where really adding multiple medications that can all cause injury at the same time can lead to some problems. Again, like we mentioned, some patients will have some hypersensitivities to this because a lot of them are going to be sulfa drugs. So again, anything but that ethicrenic acid there. And so again, rash, photosensitivity are going to kind of go along with that. And then also increases in your BUN can occur as well. As far as drug interactions go, we mentioned some of these already, but certainly by giving an NSAID, that can actually blunt that blood pressure response to that, because you're actually inhibiting those prostaglandins from being formed in the afferent arteriole. I mentioned the ototoxicity. Other big things to look at would be something like lithium. So lithium itself, does anyone know where lithium is on the periodic table, like on the left side or the right side? It's on the left side, right? It's actually just underneath sodium. So lithium and sodium get handled very similarly in the kidneys because they look so much alike. As far as, they're both cations, they both have very similar sizes for the most part. And so anytime you are putting your body in a state where it wants to hold on to sodium, it also wants to hold on to lithium, right? So if I put myself into where I'm activating all these reflex mechanisms and I increase my sodium reabsorption that I'm trying to do, then I will also hold on to more lithium, which can lead to toxicity. So that'll become more of a problem for your bipolar patients who may be on lithium. Lots of different antihypertensives can affect that. Again, digitalis or digoxin, which is a somewhat common antiarrhythmic you might see being used, or for CHF or something like that. Again, lots of electrolyte disturbances can exacerbate arrhythmias developing from that as well. So lots of drug interactions that can occur, but for the most part, if you can avoid most of them, they're pretty well tolerated. Okay, moving on, then we have our thiazide diuretics. So two ones that fall in this category would be hydrochlorothiazide and chlorothiazide. Does anyone know what hydrochlorothiazide is abbreviated as? HCTZ. Yeah, HCTZ. So that if you ever see HCTZ, that's referring to hydrochlorothiazide. I had one patient that came up when I was in a retail setting, and they asked for the Huctaz, which I thought was pretty funny. But no, it's HCTZ, sir. And then you have your thiazide-like diuretics, so these will be kind of lumped in and be considered kind of the same class. So you have things like chlorthalidone, metolazone, and dapamide. Really the big one to note here is that metolazone is really good for patients who have so all of these thiazides, if your renal function drops below, say, 30 mLs per minute, you have pretty significant renal dysfunction, these are not going to work all that well. They'd be pretty much useless, except for metolazone. Metolazone is one that will retain activity even below creatinine clearance of 30 mLs a minute. So I had one nephrologist tell me that metolazone can make a rock pee. So that was a pretty good generalization for that. So these are going to be working in the distal convoluted tubule, so it's that DCT there, and basically they're going to be inhibiting the sodium chloride transporter in that luminal membrane. It does have a little bit of carbonic anhydrase activity, but that's not something we're really all that concerned with therapeutically. And also at very high doses, you can actually see some phosphodiesterase activity. That one we're not going to worry about either until we get to more of the urology section a little bit later. So again, here this will be the distal convoluted tubule. Instead of affecting transport, it's affecting potassium as well. You will see it's mainly only affecting the sodium chloride transporter here. So again, we're going to be seeing increased excretion of sodium chloride, so that's going to lead to more water going along with that. We'll see increased urine output. Probably on a potency basis, you will not see as big of an increase in urine output as you would see with a loop diuretic, but you'll see that increase there. You're going to be losing potassium. You're going to be losing magnesium here. One big difference here is that you're not actually going to lose any calcium. So if you had a patient who say had hypercalcemia, and you want to get rid of some of that calcium, these would not be the drugs to do it, right? Your loop diuretics would, but here you're not going to have any loss of calcium. So then looking at adverse effects, you'll see these are pretty similar to what we saw with our loop diuretics. So certainly hyperglycemia can be a problem here. A lot of these all go back to that kidney compensation by doing things like activating the sympathetic nervous system and that renin-angiotensin system. Uric acid will also be increased as well for your gout patients. So indications here, again, because it's not quite so potent at getting rid of fluid, you won't see thiazides being used quite so frequently for that purpose. They're much better antihypertensives than you would see as loop diuretics. So the number one indication you'll see for thiazide diuretics will be for hypertension. Certainly they can get rid of some fluid, so you may see them in patients who have congestive heart failure, cirrhosis, and things like that. But more likely they are more than likely they'll be on a loop diuretic for those indications. And then the other thing you can see here is because we're increasing reabsorption of calcium within the kidneys, this is actually can be potentially used for basically kidney stones. So kidney stones are these calcium oxalate crystals that are precipitating out within the actual renal tubule, right? So if I increase reabsorption of calcium and I get rid of that calcium within the renal tubule, there's less calcium there to crystallize out. That makes sense? Okay. So again, these will be good antihypertensives. They work best in elderly patients, obese patients, tend to work better in African American patients, the data has shown, and then also patients who are in this more sodium retentive state, so they're just holding on to a lot of sodium. The way that this works, they think that it works, is basically that in the short term, yeah, you decrease blood volume, which decreases blood pressure, it makes sense, but your body compensates to that pretty quickly. So really, in the short term, you'll have that effect, but long term, you really wouldn't see a whole lot of benefit, which is why loop diuretics don't really do a whole lot for hypertension in the long term anyway, right? So some other things that we're seeing that thiazide diuretics do is, one, they're having some direct vasorelaxant effects, which is nice because it decreases that total peripheral resistance chronically. There's also this idea of decreasing this waterlogging that's occurring. So within the actual arteriolar walls, you're having a lot of sodium kind of sitting out there in the walls, and so by decreasing that sodium and getting rid of that fluid, you decrease some of that waterlogging that's happening there. So you'll have decreased wall thickness, you'll have increased diameter, which again is going to help reduce our blood pressure. And then it's also thought to help decrease some of your response to vasopressors like norepinephrine. You have this increased vasodepressor response. So a lot of different mechanisms, they think, to help lead to thiazide diuretics having a more chronic effect on your blood pressure than something like strictly like a loop diuretic would. So I thought it was a good picture. So if you're looking at, say, your blood pressure on the top of the screen here, you can see where you start therapy and when you stop therapy with a thiazide diuretic. So initially, you will see drops in your systolic and diastolic blood pressure. You'll see drops in your plasma volume. But you notice that over a long period of time, your plasma volume is going to compensate and start to go back up. You also see things like decreasing your cardiac output in the short term because you've decreased plasma volume. But again, that's going to go back up to normal after a period of time anyway. But you still see sustained effects in the blood pressure when you have thiazides on board because of those other effects we talked about. Make sense? See a lot of nods. Not really.
What kind of time interval are you?
This would be, say, so that first one's kind of like 1 week. Like your body will compensate within that period of time, but then it could be years here on that where you see that effect. So some of the adverse effects, obviously you can see some volume depletion by increasing urine outflow. So you'll have that increased sympathetic nervous system activity, increased renin-angiotensin system. You can also see things like hypocalcemia, very similarly, like we saw with the loop diuretics, that metabolic alkalosis, and also the hyperuricemia. Let's see. Again, very similar to your loop diuretics, see increases in your LDL. Here you can see some allergic reactions and some photosensitivity, but otherwise fairly well tolerated. Note here that the hypercalcemia, so if you had a patient who you say had chronic renal failure or something like that was already having issues with hypercalcemia, this might not be the best agent for them because again, this is just going to make that even worse. You can also see some sexual dysfunction, so it may be not good for some of your patients. So one thing to warn them about, to let them know that may require changes in types of drugs you're going to be administering, and then also you see constipation as well. Like I mentioned, thiazides are going to be ineffective at low creatinine clearances, but metolazone will retain effectiveness. It's probably a good one to know for testing purposes. As far as drug interactions go, we talked about the NSAID issue, and then also the digoxin or digitalis issue here. Lose potassium, we're going to increase your risk for arrhythmias with that drug on board. Again, low-dose thiazides, you'll see, so you can get away with like relatively low dose, say 25, 50 milligrams of hydrochlorothiazide for hypertension. You really have few adverse effects. You see more of those adverse effects as you start to pump up the dose, but for hypertension, for chronic use, you usually get away with pretty low-dose regimens.